started the recording. If you can just share your screen so that we can see. Meanwhile, everyone else kindly mute yourselves. So yeah, we can see your screen. I suppose this is the last week's presentation, is it, Dr.
Yeah.
Mitesh?
Yeah, that's true.
Yeah. Yeah. So you can begin and we are good to go. Over to you, Dr. Mitesh.
Okay, fine. Thanks a lot. Good evening, everyone. My name is Dr. Mitesh Kumar, and today we'll be starting from the reporting of shoulder joint part 2. So just a review of the checklist. Review of the checklist of shoulder joint. The first is neck, where we can have any kind of mass like thyroid, lymph node enlargement. The second is pancreas tumor, where we expect some kind of opacity here at the apex of the lung. Then we have lungs and hilum. Here we can expect any hilar mass. And in the lungs, we can expect cystic lesion, any cystic lesion or solid mass. Then in the pleura, we can have pneumothorax, which will appear as an avascular zone in this area. Then pleural effusion. Everyone knows pleural effusion. In the ribs, what we have to see is we have to look at the posterior ends, angle and anterior ends. Look for fractures everywhere. In the clavicle, always concentrate on the middle and the lateral part. Look for any obvious fracture or any step-like defect in the superior or inferior border. In the acromioclavicular and the coracoclavicular joint, again look for any widening or step or increase in the distance between the surface. Now coming forward, in the scapula, we have to look at all the parts of the scapula. For example, the blade of the scapula, lateral border, medial border, spine of the scapula, coracoid process, and the acromial process. In the glenohumeral joint, always look for features of anterior dislocation or posterior dislocation or just joint effusion. Humerus, we have fracture anywhere of the humerus, Hill-Sachs defect or reverse Hill-Sachs defect. Then supraspinatus calcification. Last is supraspinatus calcification. So from here, we'll start from the slide number 76. So like previously, I'll put on this spotter and everyone is expected to write their response in the chat box. Yes. So this is spotter number 1.
Dr.
Hello?
Mitesh?
Yes?
We cannot see your spotter collection. We can see the checklist slide.
Oh, okay, 1 minute. I'll close this one.
Yes,
Yes,
now we
is it
see
fine?
the
Yes.
spotter slide, yes.
This is spotter number 1. Everyone please write their response in the chat box. Fine, very simple. This thing we have discussed in the last class, left anterior shoulder dislocation. Okay, fine. We'll go forward. Next. Yes, few candidates have written correctly, right pneumothorax. Here we can clearly appreciate the visceral pleural line followed by avascular zone of lucency where we cannot see any blood vessels completely, starting from the base, mid and the apex, right pneumothorax. Next. Yeah, few candidates have written correctly. Very simple case of left scapular fracture. Clearly, we can appreciate that there's a displaced fracture and the fracture fragment has gone laterally. So we need to know how to look for fractures in the scapula. Either it will be complete line of lucency appearing as a fracture, or it can have a sclerotic line in which the fracture fragments are opposed to each other, hence producing a sclerotic line. So we should always know how to look for fractures in a scapula in plain X-ray. Next. I think this is a bit difficult X-ray. Only one candidate, Shreya Tiwari, has got it right. Right pneumothorax. Yeah. Clearly, we can appreciate visceral pleural line and small pneumothorax. So actually, for pneumothorax, one has to train their eyes to look for pneumothorax, and you have to slightly adjust the windows and always keep looking for a pneumothorax in all chest X-ray. Not only in FRCR 2B rapid reporting, even in a clinical practice, one has to keep looking for pneumothorax. No glenoid rim fracture. Next. Yeah, few candidates have got it right. Right third rib fracture. Clearly, we can appreciate a fracture in the posterior part of the right third rib. So the idea is that in cervical AP view, always look for the lung, pleural effusion, pneumothorax, clavicle, scapula, and the part of the humerus, which whatever is visualized. Very nicely, few candidates have picked up fracture in the posterior part of the right rib. Next X-ray. Yeah, few candidates have picked up nicely. Right scapular lytic lesion. Clearly, we can appreciate, we cannot see the scapula properly. Compare this scapula with the other side scapula. Here we cannot see the glenoid rim, the scapular blade, the cortex, but here with this side we can appreciate. In addition to that, if you notice here, even in the ribs, there are small lytic areas everywhere. So it's a right scapular lesion with some metastasis to the other parts of the rib. Right scapular lytic lesion. 1 minute. Okay, fine. We'll start. Leave it. This is another spotter. Yes, few candidates have got it right. Right humerus fracture in the neck of the humerus. Let's see the other X-ray. Now, this is another view. Here we can clearly appreciate fracture in the surgical neck of the humerus. Now let's go back to the chest X-ray. See this step. Normally we should not have any kind of. It should be a smooth line from the head to the neck and the shaft. We should have a smooth line. Here we can see this line going up, and then it's stopping here, and another line starting from here. This should not happen. So this is a fracture of the neck, surgical neck of the humerus. Dr. Sandeep? Dr. Sandeep?
Yes, Dr. Mitesh.
Do you know how to remove these three lines?
I am
Can you
actually
see?
looking for it. I have removed
I don't know
the
from where it
candidate
came.
who was messing with the sessions. So
Okay.
I'm not able to do it. Anyone from the participants, the members, the people who have joined, anyone knows how to do it?
Because the eraser
Yeah,
thing is
yes.
not getting highlighted. I don't know why.
I did notice that. So
I don't know, something wrong.
yeah, the participant who did it is not there anymore.
Okay. Okay, I think we'll move. Let's leave it and move.
Yeah,
Fine.
we can leave it
Oh,
and move.
fine.
And what you can do is try resharing your screen. So you can stop
Okay,
sharing and
fine,
then reshare.
fine.
That sometimes
fine.
does work. I
Okay,
think
fine.
candidate 4 suggested
Okay.
this. One last thing, candidate 4, there is no candidate 4 for this session. So kindly rename yourself to your actual name. We only have candidate 1, 2 and 3 for this session. No candidate 4. Yeah, so Dr. Mitesh, if you can reshare your screen,
Yeah,
I
one
think
minute,
it should
one
do the
minute.
work.
Okay, fine. Yes, done.
Yeah, so that worked. Thank you for the people who
Is it
suggested this.
fine? Another spotter. I think not many candidates are able to pick the finding. Now let's see here. Now see this. Classical. Someone wrote pneumothorax. No, no pneumothorax. See, step-like defect in the posterolateral aspect of the humeral hair. Step-like defect, Hill-Sachs lesion. Now go back here. No, this is something else. This is something else. Leave it. This is the main pathology. Step-like defect in the superior and lateral aspect of the humeral head. Hill-Sachs defect. Next X-ray. Yeah, only Only Shritika, Surekha and candidate one has written. Yeah, correct. Fracture of the clavicle and scapula here. Clearly, we can appreciate a fracture line here going to the glenoid rim. Fracture scapula. Next X-ray. Yeah, you can clearly appreciate that the cast has been put in, so obviously there has to be a fracture somewhere here, and this is the fracture. Here, clearly you can appreciate the break in the continuity of the cortex on the lateral part and the medial part. So fracture of the right humerus cervical neck. Next spotter. Yeah, few candidates have picked up well. A few candidates have written right side also fracture. Yeah, even I thought so, but I'm not very much sure. I do not have another view of this. But let's concentrate on the obvious pathology: fracture in the surgical neck of the left humerus and multiple rib fractures. And someone has also mentioned right small left pneumothorax. Clearly, we can see visceral pleural line followed by a avascular area. So this is fracture humerus and ribs and left pneumothorax. Clearly we can appreciate the rib fractures. Next line, next spotter. Left clavicle, left clavicle too, true. Left clavicle also. Next spotter. Yes, few candidates have picked up well. Right fracture of the scapula, clavicle and ribs. Posterior parts of the first, second, third, fourth and fifth rib. So I repeat again, fracture of the scapula, clavicle and posterior part of the right, fourth and fifth rib. Left posterior, no, this is not, you cannot say on this. Another X-ray. Yes, multiple fractures. Fracture of the clavicle, scapula, ribs. Multiple rib fractures, clavicle. So again, always look for scapular fracture. See, ribs fracture here. Next. Yes, fracture of the body and acromial process of the scapula. Clearly, we can appreciate fracture line here and fracture line again here. Next X-ray. Yes, fracturing the left scapula. Clearly, we can appreciate a fracture or very obvious fracture line going from here, coming here. Someone has written right scapula. No, right scapular fracture is not there. Right is fine, absolutely. Some patchy opacity seen in the right lower zone. Springal, no springal deformity. Right lower lobe consolidation, yeah, true. Next. Yes, this is springal shoulder. Here we can see high placed scapula, which is dysplastic. This is called and we can have a bone of the part of a bone connecting between the vertebral body and this scapula, which is called omovertebral body. So this is springal shoulder. Can this be rapid reporting? No, very unlikely. Very unlikely. Next. Yes, humerus fracture. Clearly, we can appreciate a fracture line here, fracture line going here, and also in the lateral part, we can see. And moreover, that we can appreciate some angulation between the neck and the shaft of the humerus. So this is fracture in the surgical neck of the left humerus. Next. Now many candidates have started picking up very well. Again, we can clearly appreciate fracture of the scapula. This is the fracture line going here and coming to the lateral border, infraglenoid part. Here we can have seeing coming to the lateral border too. So fracture of the scapula. Next. Yes, this X-ray I've already shown last time, just a repetition of what. See, in pediatric AC joint, we cannot really very much comment upon. So let's leave this part, but clearly always look at the corner of the image. Somewhere some pathology might be hidden. Clearly we can see supracondylar fracture. Last X-ray. Yes, left acromioclavicular joint widening. So this is again suggestive of ligament injury. Now compare this with the right side. Right side is absolutely fine. Less than 3 mm, I guess, is the normal, and there is no step-like defect. The line from the inferior cortex of the acromial process is touching the clavicle. So this is left acromioclavicular joint widening. That's all. So any questions? So now we have finished the shoulder part 2. Next weekend we will be dealing with elbow joint. Any questions?
So if anyone has any specific questions regarding Dr. Mitesh's sessions, please type in the chat box, or alternatively you can ask in the June group as well. So there is a question, Dr. Mitesh, from Smita B. The question is, do we have to specify subluxation or dislocation at the acromioclavicular joint?
Okay, fine. The thing is that if you are seeing very obvious large step, means the part of the scapula, the clavicle, and is just not aligning with the acromial process, then it's better to use the word dislocation. Otherwise, if some contact is maintained, then we can use subluxation or dislocation. So I guess in FRCR rapid, if it is really very much obvious, then you can better to write dislocation. Am I correct, Dr. Sandeep?
Yes, Dr. Mitesh. So suppose you write subluxation instead of dislocation, you will not lose marks. if you have identified the location and the pathology correctly, it doesn't matter if you use either of the two words.
True, true.
Yeah, and regarding there is this common query that I keep getting from all the candidates. The first one pertains to today's session. Now, before that, I would like to tell everyone that this particular session by Dr. Mitesh, the last week's session as well as today's, doesn't just show us the rapid cases, he also showed us some cases which could come in the Viva. So the cases which had multiple findings might not come in the rapids per se, but then we can get them in the Viva. In the FRCR rapids, it's very unlikely that you get a radiograph with more than one finding.
True.
So even if you get, suppose there's a very small chance that you get something with more than one finding, if you're confident about it, you can go ahead and write it. But it is rare that you get more than one finding in the rapids. And regarding the term AC, since we are constantly using AC joint, do not do it in the actual exam, you might end up losing marks. We do not know what the examiners have been told, what's there in the answer key. So follow what we do for anatomy. We never use abbreviations in the FRC anatomy exam. So for FRCR 2A, 2B, 2A, of course, we have MCQ, so it doesn't pertain to that. But then for FRCR 2B, the Viva, long case, as well as the rapids, do not use any abbreviations. No short forms, use the full term. Don't use abbreviations for anything at all.
Yeah, one thing I would like to add, Dr. Sandeep, two findings can be possible, for example, rib fracture and pneumothorax.
I agree.
So those are accompanying findings. So that is possible. Another example is joint effusion with fracture, intra-articular. So again, that those are one or two exceptions where we always should keep in mind that two pathologies can be present.
I agree with you. But still, I would still consider them to be a rarity
rather
than a common.
But maybe for 2B rapid reporting, but in Viva, if someone is showing a supracondylar fracture and the candidate does not tell about the anterior and posterior fat pad and the anterior humeral lines and the radiocapital lines, and then that reflects bad.
It does.
So in that way, there can be one or two extra findings.
I totally agree. And there's one more question from Shweta Gupta. The question is, apical pneumothorax on shoulder x-rays is a bit tricky in rapids. Any tips on that?
Always look for a visceral pleural line. You have to train your eyes. Once your eyes are slightly trained how to trace that visceral pleura and the avascular zone, what I would recommend, who has questioned this?
The question is from Shweta Gupta.
Shweta, what I would suggest you is, for example, just Google pneumothorax on chest X-ray and click on the images and try looking for at least 10 images per day. Gradually, you'll start picking up. You'll start training your eyes, and your eyes will get trained to look for pneumothorax. And for example, if you're seeing pneumothorax on a CT scan, always look for some for the plain X-ray. If you have in your PAC system, you might have a system, a plain X-ray in your PACs, and always look retrospectively to look for again avascular area and visceral pleura. So these are the ways where you have to again keep learning and train your eyes.
Exactly. So this is something which I did before my FRCR 2B exam. So during that time, I was not reporting radiographs very regularly. So I was more into ultrasound, CT and MRI reporting. But 3 to 4 months before my exam, I started reporting a lot of radiographs. So doing this kind of work, reporting a lot of actual radiographs, the real cases in your daily work, that has a lot of significance rather than just doing the subscriptions that are found online.
True.
So I guess, Dr. Mitesh, thank you so much for your sessions. Your sessions are wonderful. And
thanks,
I appreciate the excellent set of cases that you have. As someone who collects cases on a daily basis, I totally understand and I appreciate the dedication that you have in collecting these kinds of varied cases. So hats off to you. And
thanks a lot.
I would like you to join us for more sessions and take more of these presentations for the next few sessions. So we'll see how things go. Thank you once again.
Most
And we are
welcome.
very grateful to you, Dr. Mitesh.
Next elbow we'll cover in one session itself.
Yes, definitely. We shall do that as well. Thank you so much, Dr. Mitesh.
Thanks a lot.
And
Thanks,
a very
candidates.
good night to you.
Bye.
Good night, Dr. Mitesh.
Bye-bye.
Thank you so much. So thank you again to Dr. Mitesh. Now we will move on to the Viva sessions. So I will find candidate 1 and I have asked to unmute. Yeah, candidate 1, can you unmute yourself and can you speak out?
Yes, sir.
Yes, so candidate
Good
1
evening.
is there.
Is it evening or night? Yeah, good evening.
Yeah, so anything is fine. It depends on where you are. So greetings to everyone, that would be the better term. During the
All right.
exam, since I had answered the exam in Hyderabad, India, and my Viva was in the afternoon, but then during the first Viva itself, I remembered that it would be morning in the UK, so I said good morning, and they were kind of very happy about it. So sometimes they notice, although it won't make a difference in your marks, but sometimes they notice these small things. Meanwhile, I'll also unmute Dr. Smita, because it will be always good to have her feedback after the session. So Dr. Smita, if you can unmute yourself. Yeah. So I will just share my screen in a moment. And I will set a timer for 10 minutes. So today we have 3 candidates. We already have a long wait list. So since the June exam is very close now, we will try to incorporate as many candidates as possible. So 10 minutes each for the candidates and then the feedback. I am trying to find where my stopwatch is. So here we go. And candidate 1, are you ready?
Yes, sir.
So I'll be taking the first Viva for you, and then candidate 2 and 3 will be conducted by Dr. Smita. So you may begin. This is your first case. I hope you can see the screen, and there's a chest X-ray of a pediatric patient.
Yes, sir, I can.
You can go ahead.
All right. So I'm presented with the frontal chest radiograph of a skeletally immature patient with non-ossified humeral heads. I assume that this is a premature patient. There is a tubing which is seen coiled up in the upper part of the neck, which is likely suggestive of a coiled up NG tube. I can appreciate that there is the stomach is gas distended. So this is suggestive of a tracheoesophageal fistula. And further on, I would be looking at the bones where I can see that there is a hemivertebra at the, I guess, level of C5. Sorry, T5.
Could you please point it out first?
Okay.
So where is the hemivertebra that you were referring to?
I think this part is part of a hemivertebra.
Okay, anything else?
Because this is separate from the.
Okay, know that.
And
anything else?
yes, apart from that, I would also I can also appreciate that there is a gross cardiomegaly. So the echocardiographic correlation is suggested to rule out any cardiac defects. And I can also not appreciate the right humerus fully. So I'm not sure whether it is present or absent, which I would like to confirm if there are any other orthogonal views present. So considering these findings, another thing is that I would like to see the lateral radiograph of the spine if it is available to ascertain whether there are any other vertebral anomalies at the level of the sacrum and pelvis. And all these would then constitute the vectoral spectrum, and for that purpose further evaluation of this patient is suggested. I would like to inform my findings to the pediatrician, and further management and follow-up imaging as suggested can be performed.
Okay, please leave the mouse.
Okay.
You said vectoral. What is vectoral? Could you elaborate on it?
Yes, it is basically a spectrum of congenital anomalies which constitute vertebral anomalies, anorectal malformations, and the tracheoesophageal fistulas, cardiac defects, and radial abnormalities like limb abnormalities.
Okay, and regarding the cardiac anomalies that might be associated with this entity, which are the cardiac anomalies that you would be worried about?
So it can constitute the septum primum defects, it can be ASTs, and it can also be VST, mostly
Okay,
septal abnormalities.
okay. So you told me that this is a case of esophageal atresia with a tracheoesophageal fistula, right?
Yes.
How do you differentiate this particular case with an isolated esophageal atresia? So how would you say that this is not a case of isolated esophageal atresia?
So the presence of gas distension of the stomach as well as gas distended bowel loops that are appreciated. So they will help me to differentiate between esophageal atresia and an associated tracheoesophageal fistula.
Okay. So we move on to the next case. You have the
Okay.
control. You can scroll.
Okay.
The history has not been given, and you can describe your findings.
All right. So I am presented with the. Let me just check the
You
scrolling.
just click once and then use your scroll if you have a scrolling mouse. Yeah, you can
Okay.
do that as well.
Okay. Okay. So I'm presented with the post contrast CT scan chest as well as abdomen of a skeletally mature patient whose history has not been provided. So it's okay, it's not including the abdomen, so it's basically the upper abdomen and lower chest. Okay, so I'll just go through the images first before I can make any further comments. Okay, so I can appreciate that there are bilateral soft tissue density lesions which are noted along the lateral thoracic walls
Where could you point it
bilaterally.
out to us?
Yes.
Okay.
On the right side, it's over here, and on the left side, it's over here, here.
Okay.
And there is also an associated rib fracture. I think it is one of the lower thoracic left-sided ribs. I'm not sure which level, because it does not include the whole study. So considering these, and they do not show, this is a post-contrast study which does not show any significant post-contrast enhancement. I am now looking at the soft tissues for any other associated abnormality. Um,
Okay, stop looking elsewhere. Could you please
okay.
summarize your findings?
So, given the findings, I would like to correlate since the patient also has an adjacent rib fracture. This could represent chest wall. This could represent any chest wall lesion, such as a resolving hematoma on the left side, and or if there is any history of trauma, maybe.
Okay, there is no
Other
history
than
of
that,
recent trauma. The left-sided rib fracture is a very old one.
hmm so it could also be like soft tissue myxomas bilaterally. Um,
Okay, any other differential other than soft tissue myxomas given the symmetrical appearance of the bilateral lesions?
or if this is a young person, could it be brown fat
Okay, we'll go to the next
hypertrophy?
case.
Okay,
Please leave the mouse. Only
okay,
use the mouse when I ask you to do so.
all right, okay.
So here is your next case. You do not need to use the mouse for this particular image.
Okay, so I have been presented with the frontal chest radiograph of a skeletally mature patient. I can appreciate a well-defined rounded opacity, which is noted in the right lung mid zone, and it is seen. It appears to be. I can see the lung markings beneath it, so it appears to be pleural based, and I am now looking for the underlying ribs for any. Okay, the right-sided ribs are normal. There is no lytic lesion. The left-sided ribs are also normal. There is a loss of the concavity of the left hilum,
Ignore that.
and
Why are you
okay.
sure that this is a pleural-based lesion? Is there any particular reason for that?
Because the angle, like the pleural-based lesions, have an obtuse angle uh, the pleural line. So it appears to have an obtuse angle. It's not acute, so that's why it seems as if it is a pleural-based lesion.
Okay, so
And
summarize the case. What are your differentials and what would you like to do next?
so, considering a well-defined pleural-based lesion in the right lung mid-zone, I'm concerned that this could represent. I do not see any abnormal calcifications in the pleura, but still, I would keep a pleural mesothelioma as one of the differentials. Other than that, I would like to. This could be loculated pleural effusion as well, and.
So
The
what would you
possibility of
like to
this
do
being
next?
so in this patient, first of all, I would like to correlate with the patient's history of occupational history, and other than that, I would also like to see the CT scan if available.
What scan would you like to see?
If there is a post-contrast CT scan of the chest.
If you want the CT scan, this is the CT scan that you wanted, and this is a non-contrast scan.
Mm-hmm.
Yeah, you can scroll and have a look at this case.
Okay. Okay. Okay, so I'm looking at the non-contrast CT scan of the same patient. So the previously described lesion is redemonstrated, but it in the right lung middle lobe and projecting over the right lung middle lobe. It is pleural based, and it seems to have an internal fat density. So this could represent a pleural lipoma in the right lung. And other than that, I would just go through the rest of the images to see if there is any other associated abnormality.
Okay, let's wrap up the case due to time constraints. Your time is over.
All right. Okay.
Just wrap the case, summarize it, and complete the management, please.
All right, so this is a case of a pleural lipoma without any underlying rib or any other abnormality. So if the patient is asymptomatic, then this would not be treated aggressively, and the patient can be, if there is any sudden increase in size or if the patient has sudden onset of pain in this lesion, then only the management of the patient will be considered. Routine
So
follow-up.
is this a benign lesion or an aggressive lesion?
This is a benign lesion. This is a very well
What would
defined.
you
It
like to
contains
do
fat
next?
inside.
Regarding what would you like to do next? You've seen this particular set of images. What else would you do before
Mhm.
completing your report?
So I would like to correlate with the patient's history.
Okay,
If
so
the
we'll
patient
stop
has
there.
any acute complaints.
Okay, we'll stop there. You've done well.
Mm.
As a next step, you would always like to have a look at the lung window to see if there are any underlying changes in the lung due to compression by the mass. Even though this is benign, it is always
Yes.
good to have a look at what's happening in the lungs. So
Right.
10 minutes are over. You've done well. You are clear. You sound confident. You're doing well. But I would like you to speed up a bit. Speed up as in you have to wrap up the cases. You have to know when to complete and when to summarize and end the case. There's always a possibility that you can keep on looking at the negative findings and keep on describing something which is not there. So everything other than the lesion that you've already discussed about might be normal. But then there's no point wasting more than 30-40 seconds over the negative findings. So there has to be a balance between how much you say and when to summarize. So this will come with practice, but overall you're doing well. So this was the case of pleural lipoma. On the CT scan, it is very evident. So with the image itself, would you be 100% sure that this is a fatty attenuating lesion?
On the CT scan, it is mimicking the density of the fat, but
Could
still
this
we would check
be
the Hounsfield
fluid?
unit. We will check the Hounsfield
Yeah,
unit.
so always say that you will check that. It's always safe to say that before. Okay, so this was okay. You described it well, but I would not support the diagnosis of mesothelioma with this particular lesion. If
Right.
the thickening was rather circumferential or maybe more than this, this is quite a focal globular kind of a mass. So I have not seen such a mesothelioma. It is very rare to
Right.
get a focal kind of a lesion in a mesothelioma like this. So think of the other findings. You
Right.
can think of cystic lesions, lipoma. You
Right.
can think of bronchogenic cysts. No, bronchogenic cysts will be in the lung. So you can think of pleural lipomas. You can think of loculated pleural effusions. I think you said that. That is.
Yes.
And other than that, I particularly asked you about the reason why you thought this is a pleural base mass. So you said it has obtuse angles with the chest wall.
Yes.
Other than that, there is a particular sign. Do you know about the incomplete border sign?
I think I'm not sure
so
about that.
there's
right
something
now.
called as an incomplete border sign, which is useful in depicting an extrapulmonary mass, so something which is not within the lung. So what Radiopedia says is that in this sign you will have a well-defined inner border, which we can clearly appreciate over here, and the outer border will be very ill-defined. The reason for this is that in the X-ray, the beam is tangential to this part of the lesion. So
Right.
the contrast of the lesion with the underlying lung is very clear in this part. Whereas
Right.
on the lateral part, on the outer part, the beam is partially enphased or not very tangential, not at correct angle. So what happens is then the lateral half of the lesion that merges with the pleura or the chest wall, and the border is kind of obscured, as we can clearly see in this part. So you can very well appreciate that the medial border is very well defined, very sharp, whereas when we go laterally, it is very ill defined, it is very hazy. So there's a very good video about this, explaining this in a very better way by Dr. John Curtis. I will share the YouTube link on the groups after the session. So he describes it in a very, very good way. So this is the video. Can you see the screen? So this is how he explains it within 3.5 minutes why this happens. So I will ask everyone to go have a look at this when I share it. I don't think there's anyone better than Dr. John Curtis when it comes to FRCR 2B cases. And
Right.
then this case is a case of elastofibroma dorsi. So have you heard about this particular entity?
No, no.
So after this session, you go have a look and have a
Right.
quick read about this. So this is a benign soft tissue lesion, and the location that you saw is the characteristic location for that. Sometimes what will happen, they might ask you or they might show you this on a PET scan. So according to Radiopedia, you should know that sometimes this elastofibroma dorsi, it might show mild to moderate uptake on the FDG PET CT. So this should not be thought of as an aggressive lesion or a malignant lesion. So this is one of the cases on Radiopedia where there is avid uptake on the PET scan. So this is also a case of elastofibroma dorsi, this one. So then we have this last case. Okay, this you described very well. So there is esophageal atresia along with a tracheoesophageal fistula. Even if you say tracheoesophageal fistula, that would be correct. I think this is probably type C, which has atresia along with a distal fistula. But then you should know that in an isolated esophageal atresia, you won't find the gas in the abdomen. Other than that, you did well. I would suggest you to keep practicing more and try to do more cases as you go. Overall, well done. So
Thank you so much, sir. Thank you.
most welcome. So I'll share the feedback to you directly as well if you require via Telegram. Other than that, well done. So now we have candidate 2 and 3. In the meanwhile, candidate 1, please unmute yourself so that we don't have background noise. Candidate 2, are you there?
Yes.
And Dr. Smita,
Yes,
are
I'm
you
here.
there with us? So, yeah, there was no hemivertebra, Dr. Sumit. There was no hemivertebra in that particular case. So that was an overcall. Okay, so Dr. Smita, are you there with us? You are not audible. Your cardiomegaly was there. I'm waiting for Dr. Smita to unmute herself. Maybe there's something wrong at her side. Till then, kindly bear with us. Maybe if you allow me a moment, I'll just call her and discuss.
Sandeep, I cannot unmute myself. The host is not allowing participants to unmute. All right, all right. Can you hear me now? Hello? Hello?
Yeah,
Hello.
so Dr. Smita,
Yes, can you hear me?
yeah, we can hear you, but I would prefer if you are a bit louder.
Can you hear me now?
It's still not as loud as I would want you to be. Could you please move closer to your microphone?
Now, is that okay?
Yes, this is much better.
Sure.
All the participants, is this much better?
Yes, it's better.
Yeah, all right.
Yeah.
Is the candidate number 2 around?
Yeah,
Should
so
we
Dr.
Yes,
Smita,
we-
please be a bit louder. I'm sorry I'm interrupting you, but
No,
then
it's
when we
okay.
do the
It's okay.
recording of the session, then we have issues with the volume. So-
All right, fine. Can you hear me now?
Yeah,
Is
this
that
is
fine?
perfect.
Yeah. Oh,
Perfect, Dr. Smita.
yeah. Candidate 2, would you want to
Yes,
start
I'm
the
here,
case,
Dr. Smith.
please?
Okay, this frontal radiograph of chest of a skeletally mature patient. I can see well-defined rounded shaped opacity seen in the left retrocardiac area. There is a wide differential diagnosis for this. To be sure about it and for more characterization, I'd like to do cross-sectional imaging.
Doctor, could you ignore that and would you want to take another look at the X-ray, please, and give me a little more description?
Okay, there is a rounded, well-defined retrocardiac opacity seen
You can
projecting.
ignore that. I think it may be projectional. You can ignore that. It's not there.
Okay,
Yeah, the finding is
so
something
I'd like
else. Yes.
to take a general look and also see the review areas.
Yes.
Both lung apices appear normal. Both highly also appears normal. The diaphragm and postophrenic angles are okay. The bones appear normal. Lungs, both lungs are okay. I cannot see any opacities or evidence of The main abnormal, I can see that the left diaphragm is slightly elevated than normal, as it should be in a lower position than the right hemidiaphragm. There is also some irregularities seen at the left lower lung zone.
Would you like to comment on the bones? Just for, for the sake of time, I want to show you many cases because you guys are exam going. So would you want to comment on the bones, please? This is a very common kind of an exam case. So.
Okay, regarding bones, both clavicles are okay. The scapula and head of the humerus, the right head of humerus is slightly irregular with relative sclerosis to the left side. The vertebrae are not well seen. The ribs are okay. There is no lytic or sclerotic lesions. So I'm suspecting.
Are you sure?
Regarding the ribs.
Yes. Are you sure?
I can see in the right side.
Okay.
There is an anterior rib. I can see 1, 2, 3, 4, 5, fifth ribs anteriorly. There is a discontinuity along its anterior part.
Yes.
So this may be a lytic lesion or fracture. So I'd like to ask about the clinical data of the patient, if the patient known to have primary.
All right. Which is the most common primary that you're suspecting in this case, given the gender?
The gender. I think this is a female. I can see breast shadow. So this may represent if the patient is known to have a primary breast cancer, this is most likely metastatic deposit.
Okay, fine. Go to the next one, doctor, because I want to show you more cases. You picked it up. Yeah, all right. Yeah.
Okay, this is ultrasound along the lateral anterior neck. I can see a subcutaneous oval-shaped mass, which is wider than taller. It's isoechoic with well-defined borders, no calcification, no cystic degeneration. It seems to be superficial to the carotid artery and internal jugular vein. I'd like to see the remaining picture and also know the history of the patient. Available.
Okay. The patient is 3 months old and has presented with torticollis.
Okay. I can see that the lesion is inside the muscle. This is most likely sternocleidomastoid muscle,
Yes.
the left side.
Yes.
With a well-defined oval-shaped isoechoic lesion with some posteroacoustic enhancement. So I'm thinking on intramuscular hematoma. Yes, this most likely intramuscular hematoma. I'd like to confirm the diagnosis by aspiration of this lesion and refer the patient for pediatric clinic and inform the referring physician for the finding.
Okay, we'll go to the next one.
Okay.
Yeah.
This is, I think, this is the neck also, or if there is any history.
Now, in exams, they are not giving you the region. They will not mention the region.
Okay.
Give you the
I can see,
yeah.
yes, I think this is a pediatric ultrasound of the upper abdomen, where I can see that the stomach is markedly distended with thickening and elongation of the pyloric canal. The pyloric canal is stenotic and elongated, so this is a case of congenital hypertrophied pyloric stenosis.
Yes.
I'd like to urgently inform the referring physician and refer the patient for pediatric surgical team for further management. The management options could include myotomy or surgical intervention.
What do you think will be the age of the patient?
This will be days, within days or weeks in the very early in the life, as the patient has non-bilious vomiting and early in his life.
What are the complications of this condition?
Dehydration and malnutrition, maybe rupture of the stomach or, sorry?
Okay, you said it would be some weeks, right?
Yes.
Okay. Any systemic manifestation that you would be concerned of?
Systemic manifestations is related to malnutrition, as the food is not passing. Also, during examination, there will be a mass, palpable mass in the upper abdomen.
Okay, can you give me the measurements, please?
The
When
measurement.
we consider hypertrophic pyloric stenosis.
Yes, I think the total length should not exceed 17 centimeters in length. Also, in hypertrophied pyloric stenosis, the thickness of one wall shouldn't exceed 12 millimeters, and two layers shouldn't exceed 30 millimeters.
All
I'm
right.
not sure about the
No problem. We'll do a review. Don't worry. It's fine. And what would be the management?
The management is urgent referral to the urgent informs the referring physician and referral to the surgical team, pediatric surgical team. As the
Name of the surgery doctor?
Yes. As the management may need the surgical excision if myotomy is not successful.
All right. Any new advancements that you know of in this condition? That
Eh,
we can
sorry,
discuss
anyone?
here? Any new advancements for management that you know of?
Maybe botulinum
Okay.
injection.
Yeah, very good. All right. Fine. Should we go to the next case?
Okay.
All right. I'll share.
Shall I ask for remote control?
Yes, please. Approve. Yeah. Yeah. You have the remote control.
Okay. So this is axial T2 weighted image of pelvis.
Yes.
I'd like to take a general look first. I can see the uterus is okay, right ovary as well. I can see a well-defined lesion seen between the rectum and the posterior aspect of the uterus, which has a high T2 with shading effect at the rectosigmoid junction, which is pushing the urinary bladder anteriorly and the uterus to the right side. So this is a classic picture of endometrioma. I'd like to ask about the clinical data, especially if the patient has periodic pain, and also see the other.
Doctor, you have the entire scan. You can go through all the images.
Through all the images. Okay, there's other sequences?
Yes, please. Just see in different planes.
Okay. So this is the coronal image. I'm concerned about any concurrent or other lesion other than this. Okay. So I'll review my diagnosis now. This fluid distended or blood distended structure seems to have a connection with the uterus superiorly with fluid level. So this is a hematocolpus. Hematocolpus with the normal uterus. There is no congenital anomaly of the uterus. So I'm reviewing my diagnosis. This is a case of hematocolpus. So I'd like to ask about the clinical data, especially if the patient has
What is the
history
cause of hematocolpus that you know of, the most common?
imperforant hymen.
All right. And what would be your management, doctor?
I'll inform the referring physician and refer the patient for gynecology team for management.
Oh. Dr. Awal, please let me know when it's 10 minutes up, please.
Yeah, Dr. Smita, the time is up, but we can complete one more case. So I see a very
sure.
interesting case open. We can do that.
Okay, sure. Yeah, doctor, please proceed.
Okay, this is lateral radiograph of right ankle joint.
Apologies. Okay. Yes.
I didn't see
Go
it.
ahead. Ah, good. Apologies. Yeah.
I was concentrating on the picture. Okay, the main abnormality, I can see that there is a hyperdense line extending from the posterior part of the calcaneus with irregularity in the cortex at this area. This line is perpendicular to the trabeculae of the calcaneal bone.
Yeah.
The remaining bones are okay, the joints are okay, no lytic or sclerotic lesions, no soft tissue swelling. So this is a case of stress fracture of the calcaneus. I'd like to inform the referring physician and refer the patient for orthopedic team for management.
Okay, good. So what is a stress fracture?
Stress fracture is a normal fracture in abnormal bone. Usually osteoporotic patients or bone abnormal.
Are you sure?
There is stress fracture and the insufficiency.
No problem. Good. So basically, what will be the management for this patient?
Referral to the orthopedic team.
Okay.
For management.
All right. Good. You picked it up well. And would you want to do any further imaging for this case?
Yes, bone scan will be valuable in this case, and also to assess other areas like sacrum or tibia or femur, medial aspects of femur.
Has good pain only in that, as just the calcaneum. So.
Sorry?
The patient has pain only in the calcaneum, in the heel.
In the calcaneum, okay.
Yeah.
So, okay, I'll do MRI for better characterization.
No problem. Okay, so can we go for a quick review, Dr. Awal?
Yes, please, Dr. Smith.
Yeah, am I audible now?
Yes, you're audible. There's some interference, but we'll figure it out till the next session. So we are good to go.
All right. Okay, so this is a stress fracture of the calcaneum. There is a thick band of sclerosis, which is perpendicular to the cortex. There is no cortical break. And this is a spotter. I just want to show you this because even if the examiners ask, would you do any further imaging? As much as I know and the courses that I've attended, all the UK consultants have told us that there's no further imaging required for this. And radiograph is more than enough. And a stress fracture is abnormal stress on a normal bone. So it's abnormal stress. The patient is usually a runner or an athlete. And that's abnormal stress on a normal bone. And the patient would be recommended to rest. Otherwise, this can also lead to a frank fracture. All right. So we move to the next one. Okay, this one was spot on. First you went and on the axial image you said it's an endometrioma. Always go through all the images, please. Don't jump to a conclusion because it will be very odd to change it later on. And this is a spotter. You know, you don't want to miss. You can, Viva is where you can score the maximum because you have somebody to guide you. So I and Dr. Awal, we both believe that Vivas are where you can score the maximum.
Exactly.
It's just presentation. It's just presentation and the calm that you keep, you know, and they will lead you if they know that you know it. So there are two most important causes for this. One is an imperforate hymen and second a transverse vaginal septum. I would refer it to gynac department in my routine practice. And, you know, for, I think they just give an incision. And the only thing that you need to mention is that the patient may be in distress. So I would ask for a urgent referral to gynecology. That is what was recommended by my consultant friend in the UK. You don't just let it sit on and then, you know, send it on a normal OPD day. Okay, this is, as you said, congenital hypertrophic pyloric stenosis. This is, how do you remember the measurements? They will ask the measurements. You remember it by pi. So one muscle wall should be 3 mm, more than 3 mm. Candidate number 2, doctor, can you hear me?
Yes, I'm hearing you.
So just remember, because I want you guys to revise this so that you don't have to revise it again. Just fix it in your mind. So single muscle wall more than 3 mm, and in the axial dimension, the single muscle wall more than 14 mm, and the length of the pyloric canal more than 15 mm. So just remember that it's pi equal to 3.1450. I hope I've made myself clear. And secondly, you said it very well that the new innovation that they've started is they give botulinum injections in the pyloric canal so as to look for any resolution of the stenosis. And the patient is going to be approximately like in some weeks, not going to be a neonate, but probably 8 to 12 weeks. And the patient has got, because the patient is vomiting, the patient has got non-bilious vomiting and is vomiting out hydrochloride. That's the reason why the patient is going to have alkalosis. So that is the systemic complication which I wanted to get out of you. Okay, doctor, because you need to treat that. So I was just wanting to know, see these spotters, they're very simple cases. So we want to score an 8 in these, so that we can, you know, if we have some difficult cases, we can lose a mark here and there. But these spotters, you need to know everything about them. All right. Now this case, as you rightly picked up, now let me please let you know that they do not label which area ultrasound is being done. So, and history, you know, they may provide. You have to ask whether it's neonate, whether the patient is, you know, has presented with torticollis. Now, this is again a spotter. So basically, this is fibromatosis coli. You do not aspirate this, please. This is what they want to know, because this is going to disappear on its own within 4 to 5 months. So the patient will present with torticollis. He will give a history of obstructed labor, of breech position, of forceps delivery. And when an ultrasound is done, you see that there is a hypoechoic structure. It will also have flow. But the striated appearance of sternocleidomastoid is going to be distorted. Do not give it as, you know, a mass or a hematoma to be aspirated. The management is conservative. That's the only reason why they ask you this case. It's conservative management. Okay, doctor?
Okay.
Yeah. All right. This is a case that we all need to keep in mind. Whenever you get a radiograph, okay, in FRCR, as Dr. Curtis always teaches us, and I'm his huge fan, please check whether there is any mastectomy or any asymmetry. First thing that you need to see is that, you know, of the breast shadows, is there any asymmetry or mastectomy? Otherwise, you will really be jumbled. And because I know the case, I know it was easy for me, but you finally did pick up a lucent lesion in the anterior aspect of the right rib. And I would compare it with, you know, the clinical history, and the patient would require a restaging and referral to breast oncology, MDM, for further management. All right, doctor.
Okay, thank you.
Is there any question?
Thank you.
All right. Thank you.
So I will just reclaim the host from you, ma'am, and just allow me to do so, and then I will find candidate 3. We also have a candidate 3.
All right.
And I'll unmute candidate 3, and then I'll make you the host again.
Sure, doctor. Okay.
So in the meanwhile, candidate 2, thank you so much. You did well. And please mute yourself. Candidate 3, are you there with us?
Yes, sir.
Yes,
Can
so
you hear me?
Yeah, so candidate 3 is there. Whenever you're ready, Dr. Smita, I will start the timer.
Oh, I'm ready. Are you good to go, sir? Doctor?
Yes,
Can we
ma'am.
start?
Good evening. Yes, ma'am.
Good evening. Very good evening. I'm sorry. I don't know why it's open. All right. Fine. Yeah. Please proceed.
Okay. So I'm presented with the ultrasound image, which is a transverse view where I can see there is a well-defined hypoechoic cystic lesion, and which is showing internal coarse echogenic contents. And higher echogenic contents are seen at the bottom of the cystic lesion, forming a fluid level. I'm not so sure of which part this is, like I'm not so sure of the history as well. But
All right.
yeah, so okay, so this is the ultrasound of the right adnexus. So the cystic lesion, which is showing coarse echogenic contents and fluid level, it's most likely to be a mature teratoma. And so if it is like, I would like to proceed with the MRI just to see if there is any contents of immaturity, any enhancing solid components, anything that is suspicious of a malignancy. And in the ultrasound also, I would look for any ascites, which could be other sign to suggest any malignancy. But this looks like mature to me because of the thick, pultaceous looking content.
Doctor, would this be heterogeneous or homogeneous?
This one is homogeneous, but in the other image, it was showing fluid level kind.
You mean to say the depth?
Yeah, this one. Okay. Yeah, it's relatively homogeneous with the fluid level. So this can be a hemorrhagic cyst. I can see peripheral vascularity as well.
Okay. Any other differential you'd like to give, sir?
Yeah, the other differential is an endometrioma.
Great.
And so this has to be correlated with the patient's history, if there is any history of dysmenorrhea or history of irregular cycles as well. Yeah.
Oh. Just complete the case for me. What would you do next?
Yeah. So to summarize, the right adnexal cystic lesion showing hemorrhagic content in a female patient, likely to be a hemorrhagic or an endometrioma. So I would like to proceed with the MRI to confirm, and also to see any other similar looking lesion on the left side, and any evidence of endometriosis and involvement of the pelvic structures, especially the fallopian tube, the parametrial structures, to study the extent of the disease as well.
Great. Okay. This is the companion case. I would have to give you the... Okay, do you have the remote control?
Yes. I
You will have to give me a detailed description.
Okay.
Yeah. Take your time.
Okay, you mean I have to give detailed description?
Yes, please. The multiple findings.
Yeah, this is the axial T2-weighted image.
Yeah.
Where I can see there are multiple cystic lesions which are showing heterogeneous internal contents, and some amount of shading is seen in all of these lesions. So this suggests, there are hyperintense and intermediate signal contents as well, suggesting hemorrhagic contents of differing ages. And minimal ascites is also there. The uterus, it is looking normal. I have to see if there is any coexisting fibrosis or fibroid or adenoma, because this can coexist with the endometrium.
Go ahead. You have the entire scan. You can go ahead and look for it.
Yeah.
Yeah.
So uterus is looking normal.
Okay.
And the right fallopian tube appears to be distended. It is a because I can see the incomplete septations, also suggesting hematosalpinx on the right side. So I'm looking at the parametrial fat planes to see any intermediate signal deposits, but ideally a T1 weighted axial sequence would be more useful for that. So in the pre-rectal fat plane, I can see some intermediate signal which I'm suspecting of endometriotic deposits.
Are you sure?
I'm not so sure.
Do you want to change the view?
Yeah, I would like to see the sagittal view as well.
Yeah.
Okay. So on sagittal view, I can see that the uterus is normal with the maintained junctional zone, and I have to see if there is bladder involvement or not.
Okay, doctor, what are the, I'll just ask some direct questions now because I want, to complete the case.
Okay.
What are very specific signs for this condition? And can you give me, as you are thinking, can you please let me know what are you thinking of?
Okay.
Verbalize it.
Yeah, I'm thinking of the endometrioma.
All right. So what would be the characteristic signs?
Yeah, it should it will show shading on T2 and T1 hyperintensity, and there won't be any signal suppression on T1 fat sat sequence.
Okay.
And the intermediate T1 intermediate signal deposits can be seen in the fat planes adjacent to the uterus and the cervix. I mean the parametrium.
All right. So there's no suppression on T1 fat sat, which excludes it to be fat. So how would you summarize this case, sir, for me?
So to summarize, a young female presenting with bilateral adnexal complex cystic lesion showing internal hemorrhagic content and dilated right-sided fallopian tube filled with hemorrhagic content, suggesting complex tubo-ovarian mass lesions with hemorrhagic content suggesting endometrioma.
Okay.
Yeah.
And what would be your management?
So the findings has to be flagged in the report and has to be conveyed to the gynecologist. They usually go for the surgical option. Tubo-oophorectomy is the usual management for this if the patient wants to preserve fertility.
Awesome.
Yeah.
Yes.
I'm presented with the DP view radiograph of the hand. I can see that the lunate is appearing sclerotic here, and rest of the carpal bones are normal. So this looks like a lunate avian or avascular necrosis. So I have to see if there is negative ulnar variance. So it looks like there is negative ulnar variance, which might be the predisposing factor in this case. So
what's negative ulnar variance?
So that means the distal part of the ulna will not be in line with the medial articular surface of the radius.
And what is the measurement that we use?
Measurement, I'm not so sure.
No problem. No problem. Okay, please proceed.
Okay, so this is highly likely to be the Kienbock's disease, and for the diagnostic purpose, we don't need an MRI, but we have to refer the patient to the orthopedician, and because they usually go for the surgical option for this. Yeah, on the lateral radiograph, I can see that the lunate is still in congruence with the distal radius. The alignment is maintained. There is no volar or dorsal subluxation. And yeah, so it just confirms my provisional diagnosis there.
Sure.
40-year female patient. So I'm presented with the case of a 40-year-old female patient with history of pain in the lateral aspect of the knee joint. And I can see in the frontal projection radiograph of the knee joint, there is a bony fragment lying just lateral to the tibial plateau. So lateral tibial condyle, I mean, so which is the C-bones fracture, which is a very close association with the anterior cruciate ligament. So I have to advise an MRI for this patient to see if there is an associated anterior cruciate ligament injury. And even posterolateral corner structures also need to be evaluated in this case.
Doctor, are you sure it is C-bones?
It looks like, yeah, it could be a fibular head avulsion fracture.
Yes. And what would you be concerned about then?
In that case, we should be concerned about lateral collateral ligament injury because that attaches onto the fibular head.
Oh. All right. Dr. Awal?
Yes, Dr. Smita, the time is up for candidate 3.
Yeah. Okay, so can I just review it?
Yes,
Quick?
please.
Yeah, because
Yes.
it's almost 12, so everybody must be sleeping. All right. So, doctor, please check for the fibular head when you are given, we have a reflex of calling it C-bones, but if you see there is no cortical break.
Yeah.
Okay. So I just wanted to make that point that this is basically a fibular head fracture and arcuate ligament injury is what we are concerned about, as well as the cruciates will be injured. So you said very well that I would proceed, I would recommend an MRI and orthopedician referral. But just don't mix this up with a C-bones. Okay? All right. This also, it was done well. You picked it up. Now, these are spotters, so I don't want you to miss anything. It's the first session, so I want you to get it right. That's the reason you don't have to revise it again. That was my whole aim. Now, negative ulnar variance, the distance has to be 2.5 mm. Okay. The negative ulnar variance, I asked you what would be the measurement, right? Yeah, so it has to be equal to or more than 2.5 mm. And there is also a classification for Keen box. Do you know of it?
No, ma'am.
No, we don't do it in practice. Please don't call me ma'am. You can call me Smita. It's fine. We're all colleagues. Okay, we will put it in the chat box. They will not expect, but they may expect the name. Okay, so Keen box, negative ulnar variance, 2.5 mm, and the classification. Okay, there are 4 grades. All right, this case, I just want to really drill it in everyone's mind. Endometrioma. There are 2 signs which you have to say in the exam and even in your normal practice. If you see there is T2 is very important for an endometrioma because you see 2 signs. One is T2 shading, that is because of blood products that layer. And secondly, a T2 dark spot. Are you convinced? I may just find it better on the SAG. Yeah, can you see these spots?
Yes.
Dark spot. So this has got 99% accuracy that it's an endometrioma. And you have to say it in the exam. Okay, this is going to get you more marks. Otherwise, you picked it up that there are endometriomas and there is right hematocytes. And you would refer it to gynecology for further management. That was good. Okay, this one, I don't know why you first got confused with the dermoid. Dermoid would really be very heterogeneous. This is a very characteristic endometrioma. It's homogeneous, and the buzzword for this is ground glass appearance. I know it's not very common, but this is what you need to say when you get these spotter cases. They are looking for buzzwords. You got it, sir?
Yes, yes, ma'am.
Yeah, just say that so that they know that you know your stuff and your management was fine. I'll proceed with an MRI and I'll confirm my diagnosis and refer it to gynecology. That was good. Okay, I think that's all you did, or there were more cases, sir? Did we do only 4? Okay. Oh, I had one case. Maybe next time, but this is really...
Dr. Smita, we can go ahead and discuss this. I feel this is very important.
Yeah, please, this is very important.
I've earlier shared a similar case in one of my previous sessions, so please go ahead.
I really want... Doctor, just proceed with this. This is very important.
Okay, this is the frontal projection pelvic radiograph of an adult patient.
Okay.
And here in the femoral neck on the right side, the medial cortex is appearing, it is showing a small focal defect over here. And I'm comparing it with the opposite side, which is appearing smooth.
Mm-hmm.
So I'm suspecting that there's a probable lytic focus, so I would look elsewhere in rest of the bones as well to see if there are any other lytic lesions. I cannot make out anything, and I want to see the lesser trochanter as well. So on the right side, I can't see the lesser trochanter. Maybe it is avulsed or fractured. So if there is lesser trochanter fracture, most likely it is pathological. In adult patient, we should think of a metastasis as the first possibility.
Yes.
So we should do further workup for malignancy here, which should include first for the local diagnosis, we can proceed with an MRI.
May I interrupt you? What would be in your mind, or like which malignancies could cause this lytic bony metastasis? Now, made it very simple for you.
You mean the causes of lytic?
Yes, yes.
Yeah, the common causes include renal cell carcinomas, melanoma, then hypovascular, that means the thyroid malignancies, then myelomas, then plasmacytoma is like it's the solitary, and breast malignancy can be, it's a common one, breast and lung malignancies.
Okay, so you said breast, lung, renal, thyroid, correct?
Yeah.
All right. Anything else you want to comment on, or should we wrap up the case?
The rest of the findings, I think these are just degenerative changes, and just I cannot see much remarkable.
So the only thing is, it's I'm reviewing the case now. I want you to finish with management.
Okay.
Right? You have to just follow that pattern of long cases. Observation, as Dr. Awal always says, observation, interpretation, diagnosis, differentials, and management. End it there. You will have the time to talk. So please speak in that manner, and you have 15 days. So you all can revise it that way. That is what I and Dr. Awal have done for our exams. So this is basically a abnormality which is located in the lesser trochanter. There is a lytic lesion which has got a wide zone of transition. There is cortical break in keeping with pathological fracture of the lesser trochanter. Lesser trochanteric fracture in an adult is pathological until proven otherwise by literature. Okay? And because it's lytic, my top 3 differentials would be breast, bronchus, renal, thyroid. I would want to proceed, or rather I would recommend, because we recommend there in UK, here we have to speak to the consultants, our fellows, but there we have to put it on paper and everything and manage the case. So I would recommend for a search of primary by doing a CT scan of the chest, abdomen and pelvis, and refer the case to oncology, MDM for further management. And you get a good 8. You got it?
Yes.
Because you picked up everything. And do mention the words wide zone of transition, pathological fracture. These are buzzwords. You need to place them in your Viva speech and just rehearse them. Otherwise, I think you know your subject. Both the candidates, everybody actually, you all know your subjects. You passed your 2A. Now it's just about practicing these scripts. Okay. Is there anything you would like to ask me, doctor?
No, ma'am.
You sure? Okay, fine. It was nice speaking to you. All the
Thank
best.
Same here.
Dr. Awal?
Yes, Dr. Smita. So I too agree that all the three candidates are well prepared and they're doing well, but there is always room for improvement.
Yes.
And there's still time for a lot of improvement to do.
Yes.
So see as many number of cases as possible, and I thank Dr. Smita for conducting the 2 Vivas today, and we hope to see her again in the next sessions to come. Regarding the breakdown of the answers, I'll just share my screen. Dr. Smita, if you could please stop sharing your screen.
Have you, like, I'm not the host now, right?
You actually are the host.
So how should I?
Yeah, I actually was the host. I'm sorry. You just have to stop sharing. Just
Okay.
yeah.
It's fine
and-
now? Yeah.
Yeah, that is perfect. So I'll just stress on what you already said. Allow me a moment. Yes, so this is what Dr. Smita said. Can everyone see a PDF page? Dr. Smita, can you see
Yes,
the
yes,
screen? So
yes.
this is
I
the
can
final
see.
examination for the fellowship in clinical radiology part B. So this is a guiding note for candidates. So for long cases, we have to write the answers in these particular subheadings. So observations, interpretation, then comes a main or principal diagnosis. If there are any pertinent differentials, those, and then the investigation and management. So this is true for Vivas as well. Even though you don't have a table or a place to write these down, just keep in mind that you have to speak about the findings in the Viva under these particular headings. So observations, interpretation, principal diagnosis, differential and management. Regarding the interpretation, certain candidates are confused how it is different from the observation. So this clearly says you have to state whether the mass or the process or the pathology is benign, malignant or infective or neoplastic. So you have to differentiate whether it's an aggressive lesion, it's an infective lesion, benign lesion, what it is. So this is the interpretation part of it. In the long cases as well, this is what you're supposed to write. I will share this particular PDF in the groups as well. Just go through it at least twice before your actual exam. Other than that, I think we are done for today. Dr. Smita, would you like to add something to this?
No, I think you've covered everything, and everybody, all the very best. And please practice in this manner. Just keep on practicing the way Dr. Awal said, observation, interpretation, principal diagnosis, differentials, and management. End with management.
Exactly.
And you do so well. Now it's a little different. Earlier examiners were not talking, but now they are asking questions. And that is when you get the extra marks, like 7+. So complete the case fast and answer their questions, and you can score the maximum in Vivas. So all the very best, everyone.
Okay. Thank you so much, Dr. Smita.
Thanks.
Thanks to everyone for attending. We'll hopefully meet next Sunday. We'll see if we can plan a session on Saturday as well, considering that the wait list for the hot seat candidates is very long. But I cannot promise about Saturday, but Sunday, sure, there will be a session at 11 p.m. 10 p.m., 10:30, depends if Dr. Mitesh wants to continue with his rapid sessions or not. So we'll post on the groups, and I'll post this particular PDF as well. So thank you, everyone. Good night and good day, depending on where you are. Good night, Dr. Smita.
Good night, Dr. Good night, everyone.